Hi students, I welcome you all to this very important session, and that is a session on instruments in Obs and Gynae. Now this session is important for all the students who are going to appear for their PG entrance exam, now be it AIIMS, be it PGI, JIPMER, and also for students who are going to give their FMG exam. Not only that, students who are in their final year, in their Viva, you will be shown an instrument and you will be asked about that instrument. So a very important session for all of you. Hi, I'm Dr.Sakshi Arora, faculty in Obs and Gynae, and this is what I'm going to tell you, the instruments in Obs and Gynae. Now, as far as questions on instruments are concerned, if we see the PG entrance students, what are you supposed to know? See, you have to identify the instrument, number one. Number two, not only that, because in your image-based question you can be given an instrument. Not only that, they may show you an image of an instrument and they may ask you what is it used for, right? Now, what about the final year students? See, final year students, you will be given an instrument in your hand and your Viva to recognize it. So you should know how to recognize the instrument. Number two, again, you should be knowing at least two uses of each of the instruments. And you should also be having a knowledge about the related topics, right? Because your Viva can go to related topics. So in this session today, I am not only going to tell you how to recognize an instrument and what are the uses, I am also going to tell the final year students what are the related topics on which Viva can go when they have the instrument in their hand, right? So the first, I'm going to start with all the instruments which are used to examine the vagina per vaginally, right? Before I start telling you what are the instruments which are used for examining the vagina, cervix, etc., I want to talk to you a little bit about the anatomy of vagina and the anatomy of the cervix. So I have tried to recreate a model of cervix and vagina here. See, in cervix, we have two parts of the cervix. A part of the cervix, which is I'm saying is this part, this is what I have made is endocervix, right? So you all know that endocervix is the part of the cervix which is closer to the uterus. So over here there will be a uterus which I haven't made. So this part of the cervix which lies closer to the uterus is the endocervix, and it is, all of you know that it is lined by the columnar epithelium. And because this part of the cervix is above the vagina, so this blue colored part which I have made is the vagina. So it is also called as the supravaginal part of the cervix, right? Now, the part of the cervix which is inside the vagina, which I have made with pink color, right? That is the exocervix. And that is also called as the portio vaginalis, and it is lined by the stratified squamous epithelium, right? Now this opening over here, this is the opening of the external os, right? Now when you do a per speculum examination, which I'm going to tell you how you are going to do a per speculum examination and what are the instruments which you are going to use to examine the cervix. So when you do a per speculum examination, the pink colored part which you see, that is always the exocervix, right? And a red colored part, whatever little bit red colored part which you will see, will be the endocervix which is visible from the external os. Now, since endocervix is lined by columnar epithelium and exocervix is lined by the stratified squamous epithelium, the place at which the epithelium changes, that is the columnar epithelium of endocervix, it changes into the squamous epithelium of exocervix. That is called as the transformation zone. Now the position of the transformation zone, it keeps on varying with the hormonal status of the female, but mostly it is near the external os. And when you will do a per speculum examination, it will appear white in color, right? So faded appearance it is going to give. So the pink colored part is the exocervix. This white colored part, whatever you are seeing over here, is the transformation zone. The pale part, actually it's not the white part, I should say it's the pale part which you are seeing. And whatever red colored part, what you see is the endocervix, right? Now, what is internal os? Internal os is the place where the endocervix is going to open into the uterus, right? So we have an external os and the internal os. Clear? Now look over here. So in this image over here, the pink colored part will be the exocervix. Whatever red colored part you are seeing will be the endocervix, and in between them, whatever pale area you will get will be the transformation zone, right? Now suppose if a lot of red area starts appearing on the pink area, that means endocervix has moved out, and that is what is called as the ectropion. Ectropion. So in image B, you can see a lot of red colored area. That means endocervix has moved out, right? Okay. Now, if I want to do a per speculum examination, I want to look at the cervix. First thing what I will have to do is, I will have to retract the posterior wall of vagina, right? So this blue color is the vagina which I have drawn. So in order to retract the posterior wall of vagina, the instrument which I am going to use is double-bladed, non-self-retaining SIMS speculum. Why I am saying the full name is because for the final year students, when you are going to give your viva, you have to say the complete name. So this is SIMS double-bladed, non-self-retaining vaginal speculum. The other name for this speculum is the duckbill speculum. As you can see, in this speculum, there are two blades, right? One blade, the size of both the blades will be different. One blade will be a little narrow and the other blade will be a little broader, right? Then there will be a handle which will be connecting both the blades, and there will be a groove in the blade. Now this groove in the blade is for the drainage of any discharge, right? Now this is a posterior vaginal wall retractor, so I am going to retract the posterior vaginal wall with it like this. Since it is non-self-retaining, I will have to have an assistant to hold it, right? So this SIMS speculum, where is it used? It is used for in all the, whenever you have to examine the cervix. For any reason, if you have to examine the cervix, so you will have to retract the posterior vaginal wall and you are going to use this SIMS speculum there. Number two, if you are doing some minor procedures, like if you want to insert an IUCD, or if you want to remove an IUCD for that matter, or if you want to collect a pap smear, or if you have to do endometrial biopsy, in all these cases you will need a SIMS speculum. For minor gynae surgeries, vaginal surgeries, and for major gynae vaginal surgeries, again you will need a SIMS speculum. Also, a SIMS speculum can be used for the rupture of membranes in order to identify the rupture of membranes, right? So in rupture of membranes, you can put the SIMS speculum, and you can also ask, if you're not sure whether the membranes have ruptured or not, because it is not a complete rupture. It is just, some fluid is coming out. It's not that a gush of water has come out. In that case, you can put the SIMS speculum and you can ask the female to cough. And if anterior amniotic fluid can be seen coming out, that means yes, the membranes have ruptured. So in case of rupture of membranes, whether it is premature rupture of membranes or the rupture of membranes, you can go for a sterile per speculum examination. In rupture of membranes, per vaginal examination is contraindicated, but a sterile per speculum examination can be done, right? So this is a SIMS speculum. A SIMS speculum should be used in conjunction with a SIMS anterior vaginal wall retractor. So if I have retracted the posterior wall, now I need to retract the anterior wall. right? The anterior wall is retracted with this instrument. This instrument is the anterior vaginal wall retractor. As you can see, this is a tubular instrument which has got two loop-like ends, two ring-like ends, right? Now, in the ring-like ends, you have to note that there are serrations which are present, right? So, let me open an image also. So, there are serrations or fenestrations which are present in the loop-like end. Why are these fenestrations present? So that they can fit into the rugosities of the vagina. Now, if you see over here, the loop-like ends, they are making an angle with the handle, right? So they are making an angle. This is a 15-degree angle which they make with the handle, and both the loops are pointing in opposite direction. One of the loop will be pointing anteriorly, the other loop would be pointing posteriorly. When you are inserting the anterior vaginal wall retractor, the loop should be facing above, right, anteriorly, like this. So you are going to introduce it in such a manner that the loop faces up anteriorly, right? So this is how you are going to use the SIMS anterior vaginal wall retractor, which has to be used in conjunction with the SIMS speculum. SIMS speculum is going to retract the posterior vaginal wall, and the SIMS anterior vaginal wall retractor or the AV retractor will retract the anterior wall of vagina, right? Now, apart from being used as the anterior vaginal wall retractor, rarely you can also use it as a blunt curate in OBS, but that's only if final year students, if the examiner is bent upon asking you what is the other use, right? One thing which you have to remember is normally a SIMS speculum is used in conjunction with the anterior vaginal wall retractor, but if you are using SIMS speculum in SIMS position, and I'll tell you what SIMS position is just now. In that case, you don't need an AV retractor. Why? Because in that case, air will come in and it will open the walls of the vagina, right? So, Viva question. All these instruments which have the name SIMS, on whom are these names SIMS based on? So, this name SIMS is based on a surgeon who was from US, and his name was James Marion Sims. James Marion Sims is also the father of gynecology surgery. Now there are various things by the names of Sims, and in Viva you can be asked that. So number one, you have a Sims speculum. Number two, you have Sims position. Now what is Sims position? In SIMS position, you ask your patient to lie in prone position facing towards the left side, right? So the patient has to be facing towards the left side. The right arm and right leg are extended. They have to be in extended position, whereas left arm and left leg will be flexed. Right? This position is called as the SIMS position. SIMS position is very important because if you want to look at, if you want to examine the vagina, you can examine vagina in this position. For rectal examination, you can use this position, and you use this position to give the enema, right? So this is what is SIMS position, in which the patient is going to lie prone facing towards the left hand side. Right hand side leg and right hand side arms will be fully extended. Left hand side arm and left hand side legs will be flexed, right? So number one, I told you based on the name SIMS was SIMS speculum. Number two, there can be SIMS position. Number three, there is a SIMS method for VVF repair. Together these three, 1, 2 and 3 are called as SIMS triad. A very important Viva question, that what is SIMS triad, right? Apart from this, yes, we have the SIMS anterior vaginal wall retractor, and yeah, that's it. So these are the things which we have based on the name SIMS, right? Now, the biggest disadvantage of a SIMS speculum is that it is non-self-retaining. So, if I am using a SIMS speculum and I am using the anterior vaginal wall retractor, I will need assistance, right? This disadvantage, it can be overcome if I am using this speculum. This is a Cusco's bi-blade speculum or a double-bladed self-retaining speculum, right? So over here I have Cusco's bi-valved self-retaining vaginal speculum, right? Complete name is important for the final year students. Rest of all who are going to give their PG entrance or FMGE, this is a Cusco's speculum, right? Now in Cusco's speculum, it has double blades. So my Cusco's is a little old now, right? Now I am going to insert the Cusco's speculum and then I am going to tighten the screw over here, right? When I will tighten the screw over here, the Cusco's is going to tighten and it is a self-retaining speculum. So my hands are now free for whatever procedure I need to do, right? The advantage of Cusco's speculum is that it is self-retaining. So it can be used for examining the cervix in OPDs, and it can also be used for minor OPD procedures like if you want to insert an IUCD, remove an IUCD, if you want to do an endometrial biopsy or for pap smear. But there are two problems with Cusco's also. One problem with Cusco is that the anterior wall of vagina and the posterior wall of vagina cannot be seen. So if I am suspecting any problem in the anterior and the posterior wall of vagina, they cannot be seen with a Cusco's speculum. Whereas with a SIMS speculum, if I am putting the SIMS speculum, normally we put it in the posterior wall. So yes, the posterior wall cannot be seen, but anterior can be seen. But just in case I want to examine the posterior wall, then always I can shift it to the anterior wall like this and I can examine, right? This cannot be done with Cusco's. So that was one problem with Cusco's. The second problem with Cusco's is that here you are getting very less space. So this Cusco's speculum, it cannot be used if you are doing minor or major gynae surgeries. That is the biggest problem with Cusco's, right? So this was Cusco's speculum. So, and the earlier which we did was a SIMS speculum. This is self-retaining, that was non-self-retaining speculum, right? Now, sometimes you can get an image like this, where in Cusco's you can see a smoke retractor. This is a Cusco's which has a Teflon coating and it has a smoke retractor. This smoke retractor, a Cusco speculum with smoke retractor, it is used when you are cauterizing the cervix, right? So for cauterization of cervix, you use a Cusco's speculum with a smoke retractor, right? Now, I want all of you to look at this image over here and try to identify the instrument which is shown here. This instrument is definitely broader than a SIMS speculum. This instrument is Orward's weighted self-retaining posterior vaginal wall speculum. So it's Orward weighted self-retaining posterior vaginal wall retractor. I don't have this instrument here. We will see this instrument on the image. Now, if you see this speculum over here, very easy to identify because this is the only speculum which will have a very heavy weight attached to it. So no difficulty in identifying this instrument, and again it has a groove and that groove is for drainage of blood, right? Now how is it self-retaining? Cusco's was self-retaining because it had a screw, but this doesn't have a screw. How is it that it is self-retaining? Number one, because the blade and the handle, the angle which they make is less than 90 degrees and it has weight attached to it. Both these features, they make Orward's speculum a self-retaining speculum. Now, overt speculum should not be used in OPD procedures. You know, if you want to examine the cervix, you shouldn't use overt speculum. Why? Because this speculum is used only in lithotomy position, number one. Number two, it is used only under anesthesia. It has weight attached to it. It has to be used only under anesthesia, and when you remove it, so many times patient is going to complain of post-operative pain due to stretching. And it cannot be used in OPD, so it cannot be used for per speculum examination, right? Where are you going to use overt speculum? You are going to use overt speculum when you are doing vaginal surgeries, right? In vaginal surgery, I cannot use a self-retaining Cusco's speculum. And for vaginal surgeries, I cannot throughout the surgery ask an assistant to hold the Sims speculum. I need a speculum which gives me good area to operate and is self-retaining. And overt serves both these purposes, right? It will give you a proper area to operate and it is self-retaining. So when you are doing vaginal hysterectomy or you are doing TVTs, that is the tension-free transvaginal obturator tape, tension-free transvaginal tapes, or you are doing anterior colporrhaphy, in all these things, in all these surgeries, you are going to use overt self-retaining speculum, right? Now, once I have retracted the posterior wall of vagina and I have retracted the anterior wall of vagina, if I want to enter into the cervix, I will need to hold the anterior lip of the cervix. Now, in order to hold the anterior lip of the cervix, the instrument which I am going to use is the valsellum, right? I am going to use the valsellum to hold the lip of the cervix. Now, I want all of you to have a very look good at this instrument. At the distal end, it has a ratchet lock, right? In the proximal end, you can see that it is curved and it has a concavity, right? Between the blades, what I want you to notice is the gap between the blades, right? So notice the concavity which is there. Notice the gap which is present between the blades. Now, look at the tip of this instrument. The tip of this instrument has got multiple small teeth which are called as rat teeth. 4 to 5 rat teeth. So, this is a valsellum. Again, you have a ratchet lock. So, here you have a ratchet lock. Then, at the anterior end, look at the blades. They are curved. That's a concavity which is present there. This concavity, I'm just now going to apply it and show to you that when you are going to apply valsellum, the concavity should face upwards, right? So this concavity should face upwards. Then on opening at the tip, you see 4 to 5 rat teeth. Clear? Now, with this instrument, with the concavity upwards, I'm going to hold the anterior lip of the cervix. The anterior lip of the cervix will be held like this. Usually, we hold the anterior lip of the cervix, right? But a viva question could be that what are the conditions in which you have to hold the posterior lip of the cervix? So imagine, if I have to hold the posterior lip of the cervix, what am I targeting? I am targeting to look at the posterior fornix. This is the anterior part, this is the posterior part. So if I am holding the posterior lip, my aim is to visualize the posterior fornix and to do procedures through the posterior fornix. So what are the procedures which you do via the posterior fornix? Number one, culdocentesis. Culdocentesis is one procedure which would go via the posterior fornix into the Caldi sac. Colpopuncture, again. Number two, if you want to drain a pelvic abscess, that is posterior colpotomy, in that case you will have to hold the posterior lip of the cervix. Number three, suppose if you have to take any biopsy from the anterior lip of the cervix. So in that case, you are going to hold the posterior lip, right? So if you have to take any biopsy from the anterior lip. So these are the places where you have to hold the posterior lip of the cervix. So as I told you, one use of valcellum is to hold the lips of the cervix, and that's the main use. Apart from that, valcellum can be used to hold the fundus of the uterus and to manipulate the fundus of the uterus while you are doing abdominal hysterectomy, and it can be used to grasp the fibroids while you are doing myomectomy, right? So they are the other uses of the valcellum, right? Now, if you see over here, valcellum has teeth, so it is going to grasp the cervix, right? The lip of the cervix very tightly. And all of you know that in pregnancy, the cervix is very soft. So if you grasp the cervix with a valcellum, that is going to lead to a lot of bleeding. So in pregnant females, if you have to hold the lip of the cervix, what instrument do you use? In pregnant females, you do not use a valcellum, you use a sponge holding forceps. Clear? Non-pregnant females, valcellum. Pregnant females, a sponge holding forceps. Now, if you've understood this much, understand one more concept. If the female, the non-pregnant female whom you are examining is a nulliparous female, then her external os will be pinpoint. In that case, I am going to hold the lip of the cervix by using an instrument which will have a single tooth. And this instrument is called as either a single toothed valcellum or you call it as a tenaculum. So this over here, I don't have a tenaculum to show you. So this instrument over here, if you see, it is holding the lips of the cervix, but it has a single tooth. Over here, the single tooth. A single toothed valcellum has a special name, tenaculum. So now I have told you three conditions. Three instruments, right? Number one, if you have to hold a non-pregnant multiparous female's cervix, you are going to use a valcellum. If you have to hold a non-pregnant nulliparous female's cervix, you are going to use a tenaculum. And if you have to hold a pregnant female's cervix, and when do you hold a pregnant female's cervix? When you are doing a cervical cerclage. Or suppose immediately after delivery, still the cervix is going to be very soft. So immediately after delivery, if there is a cervical tear, in that case you have to hold the soft cervix again, you are going to use a sponge holding forceps. Clear? I hope this instrument is very clear to you. Again, look at it, the gap between the blades, the concavity and the rat teeth, right? Now, so in this slide, I have told you about tenaculum, how to identify it. Tenaculum is single toothed, rest everything is like your valcellum. Now, in this slide, I told you for holding the cervix, the lips of the cervix in a pregnant female, you use a sponge holding forceps. So let's have a look at how a sponge holding forceps looks like. This over here is a sponge holding forceps. Now remember, most of the forceps which we are going to study, they will have a ratchet lock. I am going to tell you only two forceps in which this lock is not there. But I'll come to that later. But first of all, most of the forceps will have a lock. Now, if you see its distal end over here, the distal end is ring shaped, right? And when you open the rings, you see serrations present on the rings, right? So it is ring shaped, it has a hole in the center, and when you open it, you see serrations. What do you use a sponge holding forceps for? You use a sponge holding forceps to paint, you pick up the swabs, cotton swab, and you paint the part before doing any surgery. Now, whether it is abdominal surgery or whether it is vaginal surgery, before doing any surgery, painting of the part is done with the help of a swab which you are going to pick up with a sponge holding forceps, right? Again, the second use of sponge holding forceps will be that it is used for holding the lips of the pregnant female, right? And lips of the pregnant female are held for cervical cerclage. Then third use is if you want to identify any cervical tears. Now when you have to identify a cervical tear, you need at least 2 sponge holding forceps. What you do is, one sponge holding forceps, you put it at 12 o'clock position, and the other you put it at, suppose this is a sponge holding forceps. This is not a sponge holding forceps, but I'm just saying imagine. Right? So one sponge holding forceps at 12 o'clock position, other at 3 o'clock position. This much part of the cervix, so I'll just show you here. One sponge holding forceps at 12 o'clock position. I don't have another sponge holding forceps. Another sponge holding forceps at 3 o'clock position. So you will examine the cervix like this. Now the one which is at 12 o'clock, you are going to remove that from there and you're going to put it at the 6 o'clock position. The 3 o'clock position sponge holding forceps will remain like that, right? So you are going to now examine the cervix between 3 o'clock and 6 o'clock. Now you will remove the one which was placed at 3 o'clock and put it at 9 o'clock. So you're going to examine the cervix between 6 o'clock and 9 o'clock. Now the one which was at 6 o'clock, you're going to take it to 12 o'clock and you are going to examine the cervix between 9 and 12 o'clock. So this is how you identify cervical tears, right? Then suppose you are doing any pelvic surgery and you want to apply pressure on any bleeder at that part. So in that case also I can pick up a swab with this sponge holding forceps. I can go deep into the pelvis and I can apply pressure, right? And now the last use of sponge holding forceps could be during LSCS. When you have given a uterine incision and once the baby is delivered, now you want to stitch the uterine incision. So you can hold the edges of the incision with sponge holding forceps. See, this is not the ideal forceps for that use. Ideal forceps to hold the edges of the uterus is either a green armitage forceps or an Alice forceps. But yes, if you have neither of them, which is highly unlikely, then you can use a sponge holding forceps also, right? So these were the uses of the sponge holding forceps. Now, in order to hold sponges, in order to paint or to hold a swab, you were using a sponge holding forceps. What about transferring the instrument from the boiler? If you have to transfer a sterile instrument from the boiler, then the forceps which you use is a Chittel's forceps. I don't have a Chittel forceps, so look in the image which I'm showing you. A Chittel forceps has a curved tip. It's very easy to recognize. It will have a curved tip, and when you will open the tip, there will be multiple serrations which are present. Very typical tip, right? And there is no lock. As I told you, I'm going to tell you 2 forceps which don't have a lock. One of them is a Chittel forceps, so no lock. One is Chittel forceps and the other is ovum forceps. Right? Only 2 forceps which you use in OBS which don't have a lock are these, and it's very easy to differentiate Chittel's forceps from a spoon-shaped ovum forceps, right? What is Chittel's forceps used for? It is used to remove sterilized instruments from the boilers and formalin cabinets. They are used to ensure that as each item is removed, others are not infected. Now, this Chittel's forceps, it should be contained in a container of methylated spirit when it is not in use, right? Now, once you have held the anterior lip of the cervix with the valcellum, now suppose you have to do a dilatation and a curettage, or you have to do MTP by suction evacuation. In either cases, whenever you have to insert any instrument inside the uterus, there are 2 things for which you should be sure of. Number 1, you should be sure of the position of the uterus, whether the uterus is anteverted or whether the uterus is retroverted. Number two, you should be sure of the length of the uterus, the uterocervical length, so that you know how much the instrument should go inside. And for that purpose, we use a uterine sound. So this over here is a uterine sound. Now, if you look at a uterine sound, you will see that it is a metal tube which is angulated. The angle is pronounced, but it is very smooth, right? So it's angulated. It has a tip which is round and it has a special name. This tip has a special name that is called as olive tip. The purpose of this olive tip is it prevents perforation. And the next thing which you should note over here is that it is calibrated. So starting from 4 centimeters, it is going up till 30 centimeters, right? Because it is used to measure the uterocervical length. So again, I'm telling you, it is a metal tube. It has a prominent angle, but the angle is smooth, right? A prominent smooth angle, olive tip, and it is calibrated, right? Now, there are two purposes which this uterine sound is going to fulfill. Number one, it is going to tell you the uterocervical length. Number two, it is going to tell you the direction of the uterus. And when you are putting the sound inside to know either of these, this is called as sounding, right? Now, apart from this, a uterine sound can help you to locate a misplaced IUCD. So, if an IUCD is misplaced and you want to see whether the misplaced IUCD is inside the uterus or it is outside the uterus, you put a uterine sound and then you get an X-ray done. If the IUCD is close to the uterine sound, you come to know that yes, it is within the uterus. If it is far, then you come to know that it is outside the uterus. Apart from that, a uterine sound can help you to detect uterine anomalies like a septa inside the uterus, right? So these were the uses of a uterine sound. Now let's talk about the viva questions which can be asked on uterine sound. Number one, when you are holding, final year students, when you are holding the uterine sound, first thing which the examiner can ask you is that what is the normal uterocervical length? So remember, the normal uterocervical length is 2.5 inches. In other words, if they ask you in centimeters, it is between 6 to 8 centimeters. Second thing which they can ask you is what is the corpus to cervix ratio in adults? So corpus, that is the uterine body, is called as the corpus. So corpus to cervix ratio in adults is 2:1, or it can be 3:1 also. But remember, in childhood, this ratio is reversed. In children, it is the cervix which is longer than the uterus. So this ratio in children is 1:2. The corpus to cervix ratio is 1:2. Then when you are holding this uterine sound, the examiner might ask you that why is it olive tipped? So as I told you just now, it is olive tipped to prevent perforation. But just in case perforation happens, what are you going to do next? So your question can come as a PG entrance student also. They can show you this instrument and they can ask you, if perforation happens with this instrument, what is the next step? So option A, immediate laparoscopy. Option B, immediate laparotomy. Option C, stop the procedure immediately and wait and watch. Option D, continue the procedure. So it is not A, B, it's C and D, right? So if perforation is happening with an instrument which is as narrow as a uterine sound, you don't need to do a laparotomy, no laparoscopy, just wait and watch. Just stop the procedure and wait and watch. You have to look at the vitals of the patient, right? This is why before putting any other instrument, we are putting a uterine sound, because it is very narrow, so it can also act as the first dilator, right? So it acts as a first dilator also, this uterine sound. And if perforation happens with this, nothing to worry, just wait and watch the vitals of the patient, right? Now, next question which the examiner might ask you is, what are the conditions in which the uterocervical length is increased? So suppose if perforation has happened, so suppose I am inserting this sound and this sound perforates the uterus. Now, in that case, I'm going to get the length of the uterus very big. I'm going to measure the length. I'm going to say, oh, this is so big length. So that means uterocervical length can be increased if there is perforation of the uterus. Or suppose if there is supravaginal elongation of the cervix. So if supravaginal part of the cervix has elongated, then in that case also the uterocervical length will increase. Or if there is congenital elongation of the cervix, there are few females in whom the cervix is congenitally elongated. Now the moment you are going to say this, the next question which examiner is going to definitely ask you and will be very impressed if you give the correct answer is, how do you differentiate supravaginal elongation of the cervix from congenital elongation of the cervix? So remember, supravaginal elongation of the cervix is seen when the uterus prolapses. And in that case, the fornixes, these fornices over here, they will become more deep. So if you are getting very deep fornices, that means there is supravaginal elongation of the cervix. But if the fornix are normal, then that means it's a congenital elongation of the cervix. And in pregnancy, see, in pregnancy, normally the length of the cervix is 2.5 centimeters, 1.25 being the endocervix and 1.25 being the exocervix. In pregnancy, the length of the cervix becomes 4 to 5 centimeters. So definitely there will be increased uterocervical length. Not only the cervix length size is increasing in pregnancy, the size of the uterus is also increasing in pregnancy, right? So this is another very important cause for increased uterocervical length. Now let's talk about those conditions where the uterocervical length is decreased. The uterocervical length will decrease in menopause. Why? Because in menopause, both the uterus and cervix are going to undergo atrophy. Suppose if there is a chronic inversion of the uterus has inverted, the fundus of the uterus has dipped down. Now, if the fundus of the uterus has dipped down, obviously the uterocervical length is going to decrease. Or suppose if you have done amputation of the cervix like you do in Fothergill's repair. In Fothergill's repair or Manchester surgery, you do amputation of the cervix. So definitely the uterocervical length will decrease. And in congenital hypoplastic uterus, the uterocervical length will decrease. Right? So these are all the possible questions which can be asked when you hold a uterine sound. But the most important question which the examiner is going to ask you the moment they give you a uterine sound is, they will say, have you seen a bladder sound? How do you differentiate a bladder sound from a uterine sound? So I don't have a bladder sound. I want you to look at the image here. In the image, what I want you to see is that in the bladder, this curve over here is very gentle. In uterine sound, this was a very pronounced curve. As I told you, it's angulated, it's smooth, but it's very prominent, right? But here, it's a very gentle curve. And the second and the most important difference is that in a bladder sound, you won't get any markings here. Whereas in uterine sound, you will get markings here, right? So, I have introduced the sound and I have come to know that what is the length of the uterocervical canal, right? Now, suppose I have to do a suction evacuation, or if I have to go for dilatation and evacuation, what I will have to do is I will have to dilate the internal os. Now, in order to dilate the internal os, I can use a set of dilators. This is a set of dilators, double-bladed dilators, which is called as Hagar's dilators, right? So, these are the Hagar's dilators. Hagar's dilators, they have double end. One end is a little narrower than the other end. They have numbers written over here which tell you what number dilator it is, right? Now, this image over here is an Hawken-Amber dilator. A Hawken-Amber dilator is always single-ended. Hagar's dilator usually is double-ended, but it may be single-ended. A Hawken-Amber dilator, it will have a blunt tip. See over here, it's round, but it's pointed little. There they will have a blunt tip and they will have a thumb rest. Right? So you will have a thumb rest which you won't have in case of Hagar's dilator. Purpose of these dilators is to dilate the cervix before performing procedures like dilatation and evacuation, or before performing suction and evacuation, or before you insert any other instrument. You are going to insert instrument during HSG. You have to put an HSG cannula. So before you put an HSG cannula, you will have to dilate the cervix, or before you do hysteroscopy. Right? So before you put a hysteroscope, again you will have to dilate the cervix. Then you will also have to do a dilatation before certain surgeries like polypectomy. So if you have to do a polypectomy, you will have to dilate the internal os first. Or suppose when you are doing Fothergill's repair. Now when you are doing Fothergill's repair, one of the part of Fothergill's repair is amputation of the cervix. When you amputate the cervix, after amputation, there is a lot of adhesions there, a lot of fibrosis there, and that leads to stenosis of the cervix. So in order to prevent stenosis of the cervix after surgery, before surgery, before performing amputation of the cervix, we dilate the cervix, right? So that is prophylactic dilatation which we do before performing amputation of the cervix in Fothergill's repair. And also you will have to dilate the internal os when you have to drain pus from the uterus, like in case of pyometra, right? So these were the uses of Hagar's dilators. Now, viva questions which can be asked on Hagar's dilators are: what is the maximum dilatation which can be done in a non-pregnant female? In a non-pregnant female, usually we dilate up till 10 number, but maximum you can take it up till 12. Then in a primigravida female, you can go up till 12 to 14 number, and in a multigravida female, you can go up till 16 number dilatation. Before you dilate, do you have to give any anesthesia? See, dilatation can be painful, so in order to prevent pain, you can give a paracervical block. Now, when you say paracervical block, the examiner is going to ask you at what sites do you give a paracervical block. So a paracervical block is given either at 2 o'clock and 10 o'clock position, or at 4 o'clock and 8 o'clock position, right? So either you are going to give a paracervical block at 2 o'clock and 10 o'clock position, or you are going to give a paracervical block at 4 o'clock and 8 o'clock position. You never give paracervical block at 3 o'clock and 9 o'clock position. Why? Why? Because descending cervical arteries, they are present at 3 o'clock and 9 o'clock position. So never am I going to give a paracervical block at 3 o'clock or 9 o'clock position, right? Now, when you are dilating, what are the complications which can happen? Number one, due to pain, they can be vasovagal shock. Number two, it can lead to perforation of the uterus. Again, if perforation happens with Hagar's dilators, you have to wait and watch. You have to watch the vitals of the patient. Remember, when you are dilating, you have to start dilating from the thinnest one, the one which has the smallest diameter, and then you gradually increase and go up till the one which has a maximum diameter. Hagar's dilator, they are 12 in number, starting from number 3 and going up till 26. So each end will have a different number. That is why we have 12 Hagar's dilators, right? Then, the third complication of Hagar's dilators could be if you are dilating forcibly. Now, when you forcibly dilate, that can lead to cervical incompetence. For all those students who feel that dilators are used to dilate the external os, remember, when you are dilating, your purpose is not just to dilate the external os. Your purpose is you have to go inside the uterus and you have to dilate the internal os, right? So basically, the dilators are used to dilate the internal os so that you can take the instrument inside the uterus, right? Now, one more purpose why I wanted to show you the dilator like this is, suppose if I ask you now a question, an MCQ, answer this MCQ for me. The instrument shown in the image is used for all except option A to measure the uterine length, option B to measure the cervical length, option C to know about the direction of the uterus, option D to dilate the internal os. So what are you dilating? You are dilating the internal os. Yes. Can you know about the length of the cervix? Yes, I can know about the length of the cervix. Can you know about the length of the uterus? No, because you are taking it only up till the internal os. You are not taking it up till the fundus of the uterus, right? So you do not measure the length of the uterus with this dilator. Length of the uterus you measure with the help of a uterine sound. Yes, it can give you an idea about the position of the uterus, whether the uterus is anteverted or it is retroverted. But it will not give you any idea about the length of the uterus, right? Now, one more use of the dilator. Can anyone think and tell one another use of dilator? One very important use of a dilator, which I forgot to mention in the previous slide, is if you have to diagnose cervical incompetence in a non-pregnant female. Now, if there is a female who comes to you and she tells you that she has history of 2 recurrent abortions, second trimester abortions in her previous pregnancies, and now she is a little afraid in conceiving. Now you are suspecting that yes, because she has 2 second trimester abortions, she could be a case of cervical incompetence. What is cervical incompetence? Cervical incompetence is when the internal os loses its tone. That is what is called as cervical incompetence. In a non-pregnant female, if I have to diagnose cervical incompetence, I can use a number 8 Hagar's dilator. See, normally if the internal os will be of normal size, when you will put a number 8 Hagar dilator, the female is going to resist, right? Because the internal os would be closed, and if you try to put a number 8 Hagar dilator, she's going to resist. But if the internal os is open, in that case, when you will put number 8 Hagar's dilator, the female is not going to resist, and you are going to come to know that yes, this female has cervical incompetence, right? So that was a use of, one more use of Hagar's dilator, right? Now, let's talk about, I have dilated the internal os. Now I want to do a curettage. Now when I have to do a curettage, I am going to use a double-ended uterine curette, or since I have a double-ended uterine curette, or I can use a single-ended uterine curette. In a uterine curette, what you have to note is that yes, it also has loops at the end, right? So ring-like loops at the end, right? And it has serrations which are present on the handle, right? Now, depending on, you have to touch the instrument and see whether it is a blunt curette or whether it is a sharp curette. So the curette which I have in my hand, one end is very sharp. So one side is sharp and the other side is blunt. So I have a blunt and a sharp uterine curette in my hand. It could be either ways. It could be a single, a single blunt curette or a single sharp curette, right? Now, this curette you shouldn't confuse with anterior vaginal wall retractor. I have both of them placed one above the other in front of you. If you look at the anterior vaginal wall retractor, if you look at the ends, they are much wider. The loops are much wider than what they are in a uterine curette. The second and the major point is that in anterior vaginal wall retractor, the ends in anterior vaginal wall retractor, although there are loops at the end, these loops have serrations. But in a curette, there are no serrations present. Third very important point, in anterior vaginal wall retractor, the serrations are present at the end. But in a curette, the serrations are present on the handle so that you can have a firm grip, right? So for a firmer grip, the serrations are present in the handle, whereas there are no serrations in the handle of an anterior vaginal wall retractor. And so this over here is anterior vaginal wall retractor. This is a double-ended uterine curette, which is used to do a dilatation and a curettage. Now, the blunt side is used to curette a pregnant uterus. So, in pregnancy, whenever this uterus is soft, I'm going to use a blunt curette. So, in case of missed abortion, in case of incomplete abortions, I am going to use a blunt curette. Or suppose after delivery, if female is having secondary PPH and you are suspecting that parts of placenta or fetal membrane have been, have retained inside. So in that case, I'm going to use a blunt curette and I'm going to check for the placenta or the retained parts of placenta or any membrane. Always in obstetrics, you use a blunt curette on a pregnant uterus except in one situation. And that one situation is after evacuation of molar pregnancy. After evacuation of molar pregnancy, you have to curette the uterus and you use a sharp curette, right? Otherwise, always for a pregnant uterus, we use a blunt curette. On the other hand, a sharp curette is used for gynecological procedures like for dilatation and curettage, or when you have to take out endometrial biopsy, or if the female is having excessive bleeding, that is atypical uterine bleeding, and you have to do an AUB, or suppose you have, in case of infertility, you want to do an endometrial biopsy, or in tuberculosis you want to do an endometrial biopsy. So you can take out the curettings and you can send it for histopathological examination, right? So after talking about the instruments which were used in dilatation and curettage, now let's have a look at the instruments which are used for suction and evacuation, right? Now, as you all know that between 7 to 12 weeks, the best method for MTP is suction and evacuation, and this suction and evacuation is done with the help of a cannula, a plastic cannula, which is called as Carman's cannula, right? Now, this Carman's cannula, it has two tips. So two openings here, not two tips, sorry, it has two openings here. One is here and the other is on the other side, right? And that is how you identify a Carman cannula, which is a plastic cannula. Earlier, we also had metal Carman cannulas, but plastic cannulas are less traumatic. That is why they are used, and then they are transparent as well, right? So, here you can see I have marked it for you on the image as well, that you are going to identify it on the basis of two triangular openings. Can you see two triangular openings? Yes? So on the basis of these two triangular openings, you are going to identify the Carman's cannula. Now, Carman's cannula, where it is used? See, Carman's cannula, it is used for doing suction evacuation for the first trimester, that is at less than 12 weeks. Then it is used for manual vacuum aspiration along with the manual vacuum aspiration syringe, which I am going to show you. It is also used for evacuation of molar pregnancy, and in gynae, it can be used for endometrial sampling. Although this is not the best instrument to do endometrial sampling, the best instrument will be an endometrial biopsy curette, right? The next thing is that what should be, the viva question is, what should be the size of the cannula? Remember, the size of the cannula should be equal to the period of pregnancy, or it should be one less. And a very important viva question is that the size of the cannula, it corresponds to what? So the size of the cannula, it corresponds to the diameter of the cannula in millimeters. So if there is a number 8 cannula, that means the diameter of the cannula is 8 millimeters, right? Now this Carman's cannula, it should be used with a manual vacuum aspiration syringe. Now it can be used rather. So this manual vacuum aspiration syringe is another very important instrument for identification. In the manual vacuum aspiration syringe, you have to remember that it has got two pinch valves. These pinch valves, they help to create vacuum, right? Then you have a collar stop. Over here at the end you have a collar stop. This collar stop, it helps to prevent the plunger from getting pulled back when the vacuum is created, and you have a plunger here, right? So it has two pinch valves, it has a collar stop, and it has a plunger. So you are going to, first you are going to close the pinch valves and you are going to pull the plunger back so that this vacuum is created inside this MVA syringe. This is called as charging of the MVA syringe. Once you are done with this, then you are going to put this Carman's cannula at the tip. You are going to attach it and you are going to release the valves. When you release the valves, then the vacuum will be transferred and the product of conception is going to come out, right? So this is how you use a manual vacuum aspiration syringe. Questions which they ask you on a manual vacuum aspiration syringe is, what is the capacity of the MVA syringe? The capacity of the MVA syringe is 60 ml. Next question is, what is the pressure which is generated by the MVA syringe? Best answer for this question would be 660 millimeters of mercury, but if 660 millimeters of mercury is not given, then only you are going to mark it as 600 millimeters of mercury. Best answer is 660 millimeters of mercury. Then, it is an alternative to electronic suction evacuation. Normally, this Carman's cannula is attached to a suction machine. But in those places where there is no electricity, then you can attach it to an MVA syringe. So in rural settings, you can use a Carman cannula along with a MVA syringe to do MTP, right? And till what time can you do MTP by this method? You can do MTP till 12 weeks of pregnancy by using a manual vacuum aspiration syringe and a Carman's cannula, right? Then, another very important Viva question is, how do you know that evacuation is complete? See, there are three things which you have to tell to the examiner for the answer to this question. Number one, you are going to say that I'm going to know that the process of evacuation is complete when no product of conception comes out, right? Number two, when you will get a grating sensation, and number three, uterus is going to contract over the cannula. So these are the three things by which you come to know that the suction evacuation is complete. Now, if you have answered all questions very well, then the next question which the examiner will ask you is, do you know that there is a menstrual regulation syringe also? This is a manual vacuum aspiration syringe. How are you going to differentiate between a manual vacuum aspiration syringe and menstrual regulation syringe? That's very easy, and the moment you are going to look at it, you're going to realize how you're going to differentiate. In menstrual regulation syringe, you have a single valve, whereas in MVA syringe, you had two valves, right? So if there are two valves, it is an MVA syringe. If it is a single valve, then it is a menstrual regulation syringe. Next important question, that what is the capacity of this syringe? The capacity of this syringe is 50 ml. Of manual vacuum aspiration syringe, the capacity was 60 ml. The last question which they can ask you here is that till what time can you do menstrual regulation as a method for MTP? Menstrual regulation, it can be done up till 6 weeks of pregnancy or 6 weeks of amenorrhea, or in other words, till after 2 weeks of the missed period. So till after 2 weeks of the missed period, you can go for menstrual regulation as a method of MTP. Menstrual regulation is done using a menstrual regulation syringe in which there is a single valve, right? Now, so till 12 weeks, we were doing suction evacuation, and we were doing suction evacuation with the help